Great. So today's webinar is brought to us by Mom's Meals. Mom's Meals has been a longtime partner and supporter of MHPA and our health plan members. They had a great presence at our conference last month in Indianapolis as both a panelist and an exhibitor. So we appreciate their longtime support and for pulling together today's session. With that, I will go ahead and toss things over to Cole Bradham to go ahead and get us started.
All right. Well, thanks, Eric. I appreciate that intro there. And first, I did want to thank everyone for joining today. I'm super excited to be here. We truly appreciate everyone taking time out of their busy days to register and join. And I hope you all will find the webinar informative and helpful and an hour well spent. Next slide. Okay. And so for brief intro, since I have the live mic, I'll go first. I'm Cole. I serve as the VP of Medicaid Innovation at Mom's Meals. And right, it's funny, I think even a few years ago, we wouldn't really associate innovation with Medicaid, but that's how far we've come in just advancing policy at the state and federal level to be able to rethink the way that we're spending dollars in healthcare and working to expand funding and resources to take a more of a preventative approach to reduce costs. And as a result of that, we're seeing a lot of payers and states invest in these innovative solutions through right, the VABs, the 1115 demonstrations, and the ILOS programs to be able to increase access to healthy nutrition. So it's been really fun to be a part of that. And within my role, I really work with a lot of our strategic partners to be able to collaborate on some innovative programs that are going to address health equity needs, but also work to influence behavioral changes and work to safely transition them back into the community post-program. And Allison, I'll turn it to you.
Great, thank you. I'm excited to be here today. I'm Alison Gustafson. I am a professor here in the University of Kentucky in the Department of Dietetics and Human Nutrition. I also am our Gatton Foundation Endowed Chair and the director of our Food is Health Alliance. And our alliance, our main mission is to bring together clinicians, community partners, researchers, industry, ag, food, health, healthcare, health insurance to really address food insecurity and improve patient health outcomes. I've been the director of that alliance for over 2 years, and we have built our infrastructure across the state so that any resident, if they so choose, can participate in a food as medicine program to reduce food insecurity and improve health outcomes. I'm going to be talking today kind of how we got to where we are. And it definitely has taken a village, if not a whole entire state, to build this approach. And so I'm excited to be here.
Okay, we can dive in, right? We're going to start with just a very brief overview of our organizations. I'll share some background, just the challenges that we're facing around food insecurity, just to help set the stage for the conversation. And then I'll go on mute and hand it over to our partner and star of the show, Dr. Gustafson, to walk you through the program. So next slide. So for those who are unfamiliar, I thought it would be helpful to provide a very brief background into Mom's Meals, just so you're fully aware of who we are and what we do. And throughout our 25 years of experience and existence, we've always been a family-owned and mission-driven organization. So I did want to lead with that mission statement, which is to improve life through better nutrition at home. And that's always going to be at the core of what we do, why we do it. I'm personally very proud to be able to work towards this mission every day. I do strongly, strongly believe in the power of nutrition, and it's been so rewarding to be able to see firsthand the impact that nutrition continues to have for those vulnerable populations who have complex needs, who really rely on meals to stay out of the hospital, right? Improve their quality of life, manage conditions, but I think most importantly, be able to remain in the community and taking a personalized and holistic approach to care. Next slide. And a little bit about Mom's Meals. So, right, we were founded in 1999. We just celebrated that 25th year anniversary, which we are so proud of. And we are the largest provider of home delivered meals. We've been able to serve over 70 million meals annually to those in need. So to me, it's been so amazing and really a blessing to be able to serve so many people across that time span who have really trusted us to provide them with quality nutrition and have the opportunity to make them a part of the Mom's Meals family. What's a little unique to our solution is that we offer fully prepared and refrigerated meals that are also medically tailored. So they're actually designed to meet the needs of members and clients of various health conditions, right? We do treat the top 10 nutrition-related deaths in the US and even have specialty programs and specific menu types to choose from based on need and preference. And then just show a very quick footprint. Headquartered in Ankeny, Iowa. We do have 3 USDA kitchens, have large fulfillment centers, and then not pictured on the map, but we also have cold storage facilities across many states that allow us to service any US address in a quick turnaround. Next slide, and I'll turn it over to you, Alison.
I should unmute myself. So I'm here today to talk about how this alliance started, what we've done, and where we're going. So the reason this is very important is that we at the University of Kentucky have a healthcare partnership with UK Healthcare amongst many other healthcare partners across the state. And that is key to building this structure. So we started with internal support from our Office of Vice President for Research and the Dean at the University of Kentucky because they saw the need for the residents of our state to improve health outcomes. So they provided my salary and time to launch this alliance. And the reason I bring that up today is when you're working with state partners, sometimes it's really key to have one central person who's in a sense holding that flag and moving the mission forward. And I'm that person. So I started to establish key pillars of our alliance, and they focus on research, policy, outreach, and training. Today, I'll be mostly talking about research and policy, but if you want to know more about what we do with outreach and training, whether it's training our clinicians, training our outreach staff like Cooperative Extension, you can always shoot me an email. I can speak to that as well. What we started was a fundraising effort with a variety of partners. So some of those partners included Instacart, obviously Mom's Meals at the Table, Beef Council, Kentucky pork producers. So we took a holistic approach of what food as medicine is and what that can look like in our state. And we wanted to make sure we had food at the table, meaning ag. We needed our ag partners at the table, especially in a state like Kentucky. And so we started to focus and shape our vision and mission based on those key definitions of food and nutrition security. So let's define food insecurity. I'm sure everyone at the table already kind of knows, but just to make sure we're all on the same table. So the USDA defines food insecurity as a lack of consistent access to enough food for every person in a household to live an active, healthy life. And this can be a temporary situation for a family or can last a long time. Food insecurity is one way we measure how many people can't afford food. And so when we keep up that mission in mind, when we're saying we want to move the needle on food insecurity, we know that it takes time. This is not a measure that moves fast, the way like blood pressure moves within a couple months, right? It's more a long-term outcome that we need to have long-term solutions for. At the same time, we don't want to just focus on food insecurity. A lot of our federal nutrition programs, that's what they were founded in. And that model thinks of calories. We want to think of whole food nutrition and think about how to improve nutrition security while also addressing food insecurity. So nutrition security is the consistent availability, access, and affordability of safe, healthy nutrition foods and beverages that promote well-being and prevent and treat disease. So that's that key distinction between nutrition security and food insecurity, is that we are focused on preventing and treating disease, whereas food security is just about providing calories. Both things are laudable, both are needed, but the Alliance is very focused on addressing both food and nutrition security, while some organizations may be just focused on food insecurity. It's a complementary concept of food security, which is defined as limited or uncertain access to adequate food. Nutrition security focuses on health equity by addressing structural racism and inequality, particularly among the BIPOC communities, lower income population, and then where I focus most of our work is on rural and remote populations. So a lot of the times the work today has been focused in the more urban communities, and we know that we need to reach our rural partners as well. So we need to build partnerships, and there is no one-size-fits-all approach. One thing you'll hear me say a lot today is that there is no one plan that will work for everyone, right? Because if there was, then everyone would offer that one option. And so we really wanted to understand, how do we build partnerships so that there's different food options depending on our customers or a patient, if you will. So we thought of this as a healthcare by food system. So healthcare by food is trademarked by the American Heart Association, which we also have funding through. But when we started to develop this alliance, we said, we need a hub, we need a centralization point. And we got those lessons from some of our other states who've been doing this work, like North Carolina, like Michigan, like Massachusetts. Recently, there was a report published on North Carolina, and many of the CBO partners were not getting the referrals that they needed. The scale wasn't appropriate for what they could handle. And there was an inconsistency in billing. And so one thing I learned in my past 2 years is that it's very cumbersome to become a Medicaid biller. So we really thought maybe we need a centralized system. And so that's where the Alliance has taken on these pain points and started to become the referral and evaluation hub for our state. So patients are screened for food insecurity among healthcare providers. So we have 4 healthcare providers that we've already partnered with. And when I say partnered, meaning we've done contracts, data use agreements, HIPAA authorization, all those details so that we can get patient health data into our hub. We've also partnered with 3 MCOs in our state, and they've referred their patients into our hub. And the reason that's important is we are relieving those pain points. We are not allowed to screen patients, but once a patient has been identified as food insecure and then has a diet-sensitive chronic disease, we, in a sense, relieve that pain point. We take it from there. We help that patient get enrolled in the appropriate program. So our step 2 in this system is we complete further screening and questions to determine the appropriate food as medicine package based on patient needs, location, and preferences. And the reason that's important is our rural folks may not have access to Instacart or may not have access to a medically tailored meal that's locally. So that's where Mom's Meals comes in, because they're able to get out into our most eastern Appalachian counties, which is very hard to get to. On the other hand, let's say we have someone who does want to grocery shop, who does want to prepare their own food. Well, then we have a grocery prescription program for them. So we need to take into account, where do you live? What are your constraints? Like, do you have a car? Can you get to the store? And then what are your preferences? And then we connect. So we have over 10 different contracts with different food providers in our state to allow for a seamless enrollment process. Patients who are lower resource, typically within Medicaid and or other government assistance programs, they need a lot of, I call it high touch, or a lot of hand holding to help walk them through that process. They're not comfortable hopping online and giving their information to somebody that they don't know. They need to have trust, and we provide that trust and we provide that connection point. The other key aspect of our referral system is we monitor patient health outcomes. And so that's that benefit of why I brought it up in the beginning, to have that university partnership. So we have data use agreements with 4 different hospital systems in our state, the 4 largest. And so we have access to that patient health information. So blood pressure changes, hemoglobin A1C, medications, and then we track over time how those patients are doing. And then the last key step that we are fairly close to being done is we are now becoming the Medicaid biller in our state. As most of you may know, if you've done this work, some of our smaller groups don't have the capacity to be a Medicaid biller, and they don't want to. And that's, again, where North Carolina, we've seen some of those pain points with our North Carolina partners, that it's cumbersome. And so we're relieving that pain point to be that referral hub, and then also to be a Medicaid biller for those that need it. So the program details, we've established those screening and referral pathways between healthcare providers and the Alliance team. So we conducted trainings among clinic staff for screening and referral. A lot of times people think the work is getting the food provider on board, but a key pain point is making sure your clinic staff are screening and referring among eligible Medicaid adults. They are burdened, and so again, we are relieving a pain point by taking enrollment off of their shoulders. So we develop data share use agreements, HIPAA authorization, and consent between healthcare providers and the Alliance. We then establish contracts with various food as medicine providers to provide a menu of options for patients. We developed platforms for us to upload patient data among providers, and then we created operations for several providers for delivery and tracking. So one big hiccup can be feedback loops. So what we've done right now is each week we upload a lack of a better word, an Excel sheet, but it's in a portal about the patients that are enrolled or the patients that have been dropped out. So the healthcare provider knows what their patient is receiving. And that's very important that we've learned from the clinic perspective. We determined program components based on food and nutrition security. So we ensured that the various food as medicine programs were compliant with American Heart Association and American Diabetes Association dietary guidelines. So what were our methods, our research methods? As I mentioned, we've started with folks diagnosed with high blood pressure, controlled, or type 2 diabetes, plus food insecurity, Medicaid, 18 to 64, and then patients at these various healthcare sites. We have now recently expanded to include referral from our MCO providers. They are screened with Hunger Vital Signs Screener. This is the standard 2-question item that is across our state and across actually every state now. And it's basically the 2 first questions from the USDA Food Insecurity Screener. Some of our providers screen face-to-face in the provider room, and some do it automatic. I can tell you right now that it's a both. One thing we'd recommend from a policy perspective is that you start with an automated screener. And the reason that's important is some people have reported to us embarrassment about answering those questions face-to-face. However, some people are not comfortable with technology to answer those questions in an automated platform, and there needs to be follow-up face-to-face. So one thing our work has really shown is that it's an and, not an or, moving forward with screening. Once patients confirmed being food insecure and agreed to wanting food assistance, their contact information is sent to our team. And this is another key point we wanted to bring up. We only want to work with folks who want assistance, right? So if someone says, yes, I'm food insecure, but I don't want assistance, we don't want to waste good resources on someone who doesn't want to make those changes. Some of the reasons we've learned of why they didn't decline assistance is they didn't want to be on a prescribed food program. They wanted to eat what they wanted to eat, right? So on that, when we think of the behavior change wheel, they're at the beginning. They have no desire to change. Another is they don't trust sharing their information. And so that's something we can start to really build on the clinic provider side, is building that trust. And the third, which is a really key point, is they didn't understand that there were different options for food. And that's a key piece because, again, some people want to be able to shop. Some people don't want to shop. They don't want to cook their own food. And so in the very beginning, when that provider is telling them about these programs, that's the key moment that they can say it's free, it's part of your insurance, and there's options. And then back to the referral. So each week, clinic nurses upload that patient information into REDCap, and then we complete further enrollment. So we complete further informed consent survey, and then we do have significant personal time to assist patients with key aspects related to what programs they're enrolled in. So sometimes it's setting up their grocery cart, confirming allergies, food preferences. And the reason, again, we have that referral hub is they trust us, right? So people and even think about your own experience. You like to know that you're talking to someone who lives in the county next to you or in the city that you're living in. And so we provide that trust with our patients. So what do the food as medicine components consist of? Most of you who are familiar with Mom's Meals, I'm just repeating, it's 12 weeks, fully prepared meals. They got 10 per week and they're tailored for either type 2 diabetes or high blood pressure. And these were delivered from Mom's Meals. We also send weekly text messages or nudges to make sure that this is a supplement. This is not their whole caloric diet. So we provide them information on food coping strategies, way to stretch your food dollar, tips on grocery shopping to supplement what meals are already being delivered. And then we did offer 30-minute nutrition counseling, since we have a host of registered dietitians, every other week, if they so chose. So in the grocery prescription program, those folks received either a card that has that can be utilized at grocery stores, and typically in more urban communities, for lean protein, fruits, vegetables, low-fat dairy, and eggs. And then meal kits were also provided if that's the arm they went into. And that is similar to HelloFresh, but way more affordable, not as fancy. And it contained food to make 4 meals, about 4 to 6 servings per week. In all of these arms, they all got weekly text messages related to recipes, videos, and behavioral nudges. They also got reminders in the grocery prescription program about utilizing remaining funds. We didn't have to do that very often, but I know sometimes in other programs they have had to. We did not have to worry about that. Again, they all got ways to stretch your food dollar, and they also got 30-minute nutrition counseling sessions. So what did we find? We found with grocery prescription, there was a significant reduction in blood pressure. With medically tailored meals, there was a significant reduction in blood pressure and hemoglobin A1C. And meal kits, we did not see a significant change. However, there was a trend toward decreasing blood pressure. What's really important that I'd like to stress is this next finding. So 50% of our sample were enrolled in SNAP, or Supplemental Nutrition Assistance Program, formerly food stamps. And we wanted to understand, how can a food as medicine program supplement or add to those who are already enrolled in SNAP? So we looked at those who were in SNAP relative to those who were not in SNAP. And so what you'll see from left to right, for medically tailored meals, the systolic blood pressure decreased by about 22.68 and diastolic decreased by about 12.05. So those who are on SNAP that also received a medically tailored meal had a significant decrease in blood pressure. They also decreased their hemoglobin A1C by 4.15. We did not see a shift in body mass index, but I will reiterate, our food as medicine lens is not one about weight loss. It's about improving diet and improving clinical outcomes. I'm going to pause on that. That medically tailored meal among SNAP, when we think about what that supplementary effect can do for our SNAP customers, is really important. And conversely, this is everyone's food insecure, everyone's low resource. And so this is those who choose to be on SNAP versus those who choose not to be on SNAP for whatever the reasons. It might be, other environmental barriers. So this is a key policy moment that we can leverage. How do we help our managed care plans make sure that those who are participating in a food as medicine program are also participating in federally nutrition programs? 1. 2, those who participate in a food as medicine program, if they are enrolled in SNAP, how do we make sure they continue to enroll in SNAP and utilize what they've learned over that 12-week food as medicine program, or 24-week, depending on your state, depending on your CMS guidelines? How do we make sure they're then using their SNAP dollars in a healthy way? This is such a critical piece of information that I want to stress over and over, and I'm really hoping our policy leaders see this as a great way to leverage federal nutrition program with Medicaid. The next, we see it with grocery prescription as well. So we had a drop of 14, and then in systolic, and about 7 in diastolic. Not as much of a shift in hemoglobin A1C. The way we did with medically tailored meals. And this should not be a surprise, right? When you're giving someone a very prescribed, meal that they're supposed to eat, you would expect greater outcomes, or I would, at least as a researcher. So meal kits, we did see a decline, and I should have had an asterisk. We did see among SNAP with the meal kit a decrease of about 7 in the systolic and about 8 in the diastolic. No change in hemoglobin A1C. And again, not surprising given that you have to cook that food, right? And you have to follow a recipe, and you may throw it out versus that medically tailored meal. So how did participants use the extra funds from receiving these programs? So from an economic perspective, that you are giving a financial support, right? Whether because those resources they would have maybe spent on food, they could spend on other things now. So a lot of people reported that they paid utility bills. And what I was excited to see is they spent more on fruits and vegetables. So they used those extra funds and they spent it on additional healthy food. I think a lot of times there's a narrative that people who are food insecure or lower resource aren't making healthy choices. I find that to not be true in our work across the state, that when given opportunities to purchase healthy food, they are. And they also purchase household items like toiletries and cleaning supplies. I'm not advocating that Medicaid should be covering cleaning supplies. What I am saying is sometimes if a person is in a temporary situation for food insecurity, providing them with food also lifts them up for other social constraints and economic constraints. And so our study found this so far. So I just always like to have the lived experience in our presentation. So what did participants say? They said, "Thank you so much for everything you are all doing. It's so amazing, such a huge help for people." And one person said, I would like a greater variety of food options. And I think this is really important when we think of the user experience, is that we continue to make sure our food options are meeting their preferences, right? Because otherwise they won't stay engaged and we won't see that reduction in blood pressure and hemoglobin A1C. And we asked, what would you change? And one person said, I wouldn't change anything. Another said, it's going to help a lot because it's hard to afford fresh food. We eat a lot of pasta, ramen, and food bank food. And the reason I bring that quote up is lots of our partners are food banks. But I think what's important to remember is when we're thinking of food as medicine and tailoring, food banks to date have served a great role on hunger reduction and food insecurity. And we now want to make sure we're focused on nutrition security as well. And so food banks have a great opportunity to be part of this dynamic, but we need to work with them for capacity building so that they're potentially giving meal kits that are lean protein, fruits, vegetables. We don't want our participants going to a food bank and receiving a meal kit with some healthy food and then some unhealthy food. So I think it's important to remember that everyone can be at the table. It's just we all need to make sure we're focused on that same mission of food and nutrition security. So what was our enrollment rate? So remember when we talked about people being screened and then coming into our hub, how did we do with enrollment? So we had 60% enrollment rate. There's room for improvement in how to engage patients once they've been screened for food insecurity. Our managed care partners thought our enrollment rate was pretty good relative to other ones that they've participated in, but we know we can get it up to 80%. What we're very excited to show is that 96% retention rate. Once we have the customer or the member in our hub, they don't leave. So for 12 weeks of patients who completed the baseline survey, our team had a very high touch patient interaction and built-in trust. That referral hub concepts just reiterates that when we are available to that patient and we meet their needs, like for example, let's say the mom's meal came and now they want to change it. We respond to them within 4 hours that no problem, we'll change your meal. Let's say they call and they say, I lost my grocery prescription card. Within 4 hours, we say, we will get you a new card. And patients need that moment to be reassured that their need is going to be met and that we can do that for them. And then lastly, overall, we definitely found a significant decrease in blood pressure. And those who utilize SNAP, though, with MTM and the grocery, we found an even greater differential effect among SNAP relative to non-SNAP. So I want us to all think about how to enroll in SNAP while also offering a food as medicine program. We can structure this program to allow for SNAP enrollment after completion of the food as medicine program. It's such an important policy lens that we all can take on this call. So food medicine programs work, but need to be tailored for user preferences and constraints. That's a key takeaway in that there is no one size fits all. So one thing we'd like to focus more on in our next work is someone who is stage 4 hypertension perhaps would be doing well with a medically tailored meal, whereas someone who's stage 2 and likes to cook would do better with like a meal kit or a grocery prescription program. So to date, a lot of the research and a lot of the programs coming out of Medicaid say, we offer a grocery prescription card and that's it. Or we offer medically tailored meals and that's it. That probably isn't the best way to engage with our members or our patients, and it doesn't meet their preferences, and thus they won't stay engaged in the program. So we are advocating for it's called a stepped care approach. And so that depending on the patient and depending on their needs is what program they would get. So what are some really strong lessons that we've learned, which is a lot? So health-related social needs can be a covered medical benefit under CMS guidelines. For long-term sustainability, health insurance and state governments need to cover this benefit. We've been operating a lot in our state on grants, and so we are coming to that point that this needs to be a medically covered benefit. Some states are already there, like we've mentioned, Michigan, North Carolina, but there's a lot of states that are not there yet. And one avenue could be in lieu of service and can be also value-added benefits with MLR consideration. Another key point is screening and referral need to be a billable expense for healthcare providers to ensure that screening and referral occurs. So right now, some states and some programs, they are screening for food insecurity, but at the hospital level, not at the clinic level. So an example would be like a diabetes, like our Barnstable Brown Diabetes Center. They don't have to screen for food insecurity. but that would be a clinic that we would want to screen for food insecurity. We also need to make sure it's just part of standard of care, whether it be automated and face-to-face. So as I mentioned earlier, we really think it's an and approach in order to capture people's sometimes embarrassment around answering those questions. A host organization, and I call it a referral hub, needs to serve as the central point for referral billing and feedback loops between providers, insurance, and food partners. We've taken those lessons from other states, and as we've built this in our state, we see relieving pain points from many partners, relieving pain points from the clinicians and community health workers so that they don't have to worry about enrollment, relieving those from community health workers or nurse case managers at MCOs, so they don't have to be calling their members back every week saying, did you get the grocery card? Or how are you liking mom's meals? But we know we need to do that for our patients in order for them to stay engaged and to move the needle. We also know that billing can be cumbersome at best. And then lastly, contracts. So we relieve, again, that pain point between contracts between the MCO partners and then the food provider. And then we also need greater capacity for food partners to reach rural and remote locations. So we have some providers that are able to get into our rural and remote areas, but in order for us to all ships to rise, we know we need to increase our capacity among those partners. The last point for lessons learned is we need focused efforts are needed to help roll patients off into federal nutrition assistance program after completion of the program. So that program, whether it's 12 weeks or 24, depending on your situation, your state, either way, we want them to be able to roll into SNAP, roll into WIC, roll into TANF, senior meals. And so we need a referral person that can help that person do that. And so we know there's laws around SNAP and Medicaid. So Medicaid is not allowed to refer into SNAP. So that's why this hub can, again, serve that function. And so when you have hubs in your state that are not within the Medicaid, they can function where they can help people roll into SNAP or WIC. We also know that during the time while they are participating in the Food is Medicine program, that is a key behavior change moment where you can help them to then understand how to use their SNAP benefit or their WIC benefit in a healthy manner once they've rolled off of this food program. So what are some limitations about what we've been doing? Overall, we know it's only 12 weeks, which limits ability to detect differences for outcome. Ideally, these programs would be for 6 months and allow for referral into longer-term nutrition assistance program. We conducted a feasibility study in our state, and so we weren't powered as much as we'd like to be. And the reason I bring that up is we now are at a place, what we're doing with American Heart Association, where we are powered. We have more of a sample, bigger, thousands of people to then look at that change in blood pressure and hemoglobin A1C. And I would argue that we'll probably see even greater improvements. We did not conduct a randomized control trial. And the reason is for ethical concerns. So screening someone for food insecurity and then not offering them a program is not ethical. So we conducted a programmatic RCT, and that's where we allotted people to different arms depending on their preferences and constraints. We believe offering a user preference approach or tiered approach in the future is an appropriate model to consider. So what's our public health impact? Where do we go from here? Food as medicine programs are one piece of a larger system to reduce food insecurity and improve health outcomes. These programs have potential to have large impacts in the short term, but require significant buy-in from stakeholders across multiple sectors for success. Sorry. And the reason I say that is it is not just health insurance, and it is not just one food provider. So we've partnered a lot with Beef Council, Kentucky Pork Producers, Organic Association of Kentucky. So we need to make sure that the food providers are at the table, also grocery, right? So there's no one partner that's leading this mission, but we want to make sure we're working collectively and collaboratively rather than working in silos. So I'd like to take the next couple minutes to talk about our American Heart Association current grant. One second. So we've now looked at the development of a user-centered design for screening, referral, enrollment, and engagement. And so what we've done is we've tailored through a screening decision tool. So we've developed a tool that now asks people, do you have a kitchen? Do you have cooking utensils? Do you have access to transportation? Do you want to cook your own meals? Do you not want to cook? So based on that, we've had people silo out into various food as medicine packages. And our enrollment rate, as I mentioned earlier, has gone up. We are now at an 80% enrollment rate. And so far, no one has dropped out from any of the programs. And so the reason that matters is we've shown that a third went into medically tailored meals, about 50% went into grocery prescription, and about 20% around are in meal kits. We're not taking away the role of produce prescription programs, but we know in order to move the needle and dietary guidelines, we need some sort of protein option in our food as medicine packages. I think produce prescription programs, especially coming from a farmer's market, have a place at the table, and we want to see those as a supplement to what's going on, but we want to make sure across our state that we're meeting those dietary guidelines. So we need to help create systems for how to refer after the program ends. So one thing we've recently launched, and literally recently in the past 2 weeks, is we're working with our state SNAP leaders in how the Alliance can play a role in SNAP referral and enrollment. So what we've just launched in the past 2 weeks is, of the people that have enrolled in our food as medicine program, we found it keeps happening, about 50% are not enrolled in SNAP. So we are now calling those participants who are in a food as medicine program who are not in SNAP, and we're asking them if we can connect them to a SNAP enrollment person in our state. Overall, everyone is saying yes. So because we have that built-in trust, we then have a call in to it's called a KY Nectar. I'm sure in your state, they're called something else. Since we're not a Medicaid provider, we're allowed to conduct that SNAP referral. We then follow up with these individuals 2 weeks later to see if they've been enrolled in SNAP and if they have any questions that we can help them with. So far, that process has helped us enroll about 25% of the 50%. We would like to also look at this with WIC, TANF, and some other federal nutrition programs. I think this is a key piece if we are wanting to have even greater outcomes and move the needle more on our food security, is making sure we're also enrolling them with SNAP. As I mentioned, we're utilizing that screening decision tool to allocate patients. And the reason I bring this up is we've had 3 people started that they wanted a grocery prescription program, and then they actually moved over into mom's meals because they didn't want to actually grocery shop for themselves. They thought they did, and then they didn't. And the reason that's an important insight is that, again, if you're a Medicaid provider and you're offering one program and your member doesn't like it, they're going to just drop out. But offering options, I think it just improves your chances that they'll stay engaged and have improved health outcomes. So thank you for all your time today. And now I believe we can leave it open for questions.
Yeah, we'll take a look at questions. And Alison, I think that was awesome, just providing that overview of the program and the research policy, and I think all the different components that go into the success of the program that are so important, but could sometimes be forgotten or deprioritized. You hit on this, but I think a key takeaway and just something to remember is that, right, it's not that one size fits all approach. It's so critical to remember that assessment component is going to be so critical to be able to ensure each person's being cared for in that holistic way, and effectively addressing those inequalities among the diverse population. And pilots like this have been so critical to evolve food as medicine programs. So I just really applaud the efforts here, everything that went into the design of this program, and are very proud to be a partner associated with it. There's also opportunity to incorporate different solutions into one program and look at a step down approach, right? From meals to produce or grocery. And there is some interesting data that's also available around the effectiveness there as well. And I think another just key takeaway that I'll emphasize too is that, right, we hit on this, but it's not always just about hunger. We have to consider the quality, variety, and frequency of meals. And it's why, we're shifting that conversation to address nutrition security, right? That complements food insecurity, but it's actually very different. And the type of food matters as a way to, right, manage and treat and prevent specific diseases. So it's been great to work with the Food Alliance over the last few years as well, to just advance these food as medicine programs with proven outcomes. I'm excited Dr. Gustafson was able to share just how this program was structured, and then right where we could look to, where's there's opportunity to replicate this model, evolve and scale it, because there's so many great innovative programs coming down at the state level, which could really take some best practices learned from this type of model. So yeah, again, thank you all for joining. We do have some questions that came in the chat, so we will take a look. If anyone has any other questions, please feel free to go ahead and enter them. But Allison, do you want to take any specific questions? I'm pulling up the list right now as well, but if you see any that you want to jump on, feel free to call them out.
Oh, I'm not seeing them. Okay.
I can call them out to you. It looks like a lot of them.
I cannot see that.
Okay.
I don't know why.
Oh, that's all right. I can call them out.
Okay.
Any
Oh, now I see
questions?
them.
I did. Okay. Any questions about just like the tools for referrals? You can probably speak to that one a little bit better.
Sure. I'll just start with this first one that I see. Are all healthcare providers and MCOs using the same screening tools? Yes, they are all using the two hunger vital signs screener, the first two questions on the USDA 6-item food insecurity screener. The one thing we've added in our hub, just so you know, is the nutrition security questions. So there is it's a real easy one question on nutrition security. So we've added that to look at that change as well over time. The next one said, do healthcare providers have to be the ones to conduct the screening for enrollment to be reimbursable? No and yes. Healthcare providers or your MCO needs to do that. So that's part of that. What we'd really like is for it to be, it is standard of care at the hospital level, but we want it to be standard of care across clinics because you will have greater reach, if that makes sense. And then second, our MCO partners. And so when we think about that, it pretty is well established that screening is standard of care. Now, does everyone do it all the time? No, they don't. But that's what we're trying to get to. Is there any prepayment made to the direct food as medicine programs providers? Seems like payment for Medicaid alone. Yes, revenue cycle management has been an issue that has come up for our smaller food providers. So Jordan, that is why we are advocating a referral hub. So we can take the burden of in a sense, we can pay our food provider and have there be a delay where we are reimbursed from the MCO. And so we've learned from our counterparts in North Carolina that CBOs can't handle that delay in payment. And that's why we're advocating this model of a referral and billing hub to take away that pain point. Are the meals, grocery prevention meal kits only provided to the individual? We are actually having another project that will look at the whole household. I can tell you this, in our analysis, well, first let me start. Only 25% of our enrollees had children under 18 in the household. So I think a lot of times people are thinking there's a lot of kids in these households. There's not, there just really isn't. But second, yes, we are looking at a model where the adult would get the medically tailored meal, and then they would also get a grocery prescription card to provide healthy food for the child or children in the household.
And hey, I can jump in there too.
Oh yeah, Cole, jump in on that.
Yeah, just from like experience with some of the programs that we've ran, and right, each state's gonna be a little bit different. I think there are some states considering looking at that household model, which of course is going to be best practice. I've particularly seen it more effective or just very practical to provide meals for the household when it's a maternal program, just taking into consideration, right, the time that birthing person has when they come home from the hospital, just fatigue, energy, being able to prepare meals. And, if you provide them with meals, if there are other children in the household, likely going to defer the meals to the kids prior to eating themselves. So we need to make sure, right, mom, baby, all kids in the household are having access to nutrition. So I just want to jump in with that thought.
Thank you.
Of that program too.
Yeah. Thanks. And I think there is a little, you know me, I'm a researcher, so I think there's still a little bit of research to understand, is it better to give the medically tailored meals to everybody? Is it better to give MTM plus a grocery? Is it better to do, you know, just kind of those different nuances. But that again is that tailoring. So finding out how many people are in the household and what are those ages. So I think that's important. We don't find issues keeping in contact with our enrollees. And here's why. We are on the phone with our enrollees and texting them, you know, on a weekly basis. So running out of minutes for the month, phone number changing, we're just constantly in contact with them. So that's where we have that 96% engagement rate. So we really don't find that we have an issue. So our current American Heart Association grant, we had 2 people in the hospital and their spouse called to tell us that they were in the hospital. And so we needed to pause their program. So there's just that, really is that high touch. Did you run into any issues with any of these programs unintentionally affecting WIC? No, they do not affect any of their SNAP or WIC eligibility. We've really focused a lot on that. They didn't have to report those benefits at all for SNAP, and they will not have to. The last I heard from CMS, they would not have to do that. No, I'm not CMS, but that's the last I heard, that they would not have to report that as a benefit because it's covered under their insurance.
Yeah, and I think that SNAP and WIC enrollment piece is critical because, right, all these programs are going to be transitional. They're not designed to last forever. So eventually we do have to find that safe and effective way to transition them back into the community and take a look at what available resources there are. So that SNAP and WIC is, you know, part of the process. It's part of, you know, how states should kind of be viewing these programs, how health plans should be considering it to make sure, right, health plan, case manager, right, meals provider, whoever that may be, right, there's a responsibility to discuss that with them and ensure that, you know, they have awareness, they have next steps on what else is available out there to help lead to more sufficiency and sustainability to the program's success.
And then one other piece on that, we know that a lot of our providers, this next question, does the Alliance address more than food-related issues? So we also know that we'd like to be that hub that provides, you know, housing vouchers or transportation, whether it be like Uber or DoorDash, that kind of thing. So yes, that is why we're setting this model up, so that if this is what we can do for food, what can we also do for the other health-related social needs? Again, we've only been in existence for 2 years, so we're getting there. But that is ideally what we'd like to show is how that model can work. So does enrollment rate differ across demographic categories? No, it does not. So our enrollment represents our state. So about 30% were Black African American, 3% were Hispanic, Latino, Latinx, Latina, and then the rest are white Caucasian. That represents our state. And then we also had strong enrollment, rural and urban. So we did a pretty strong job about representing what our state is. Can you say more about the types of prepared meals that were provided? Sure. And I'll also have Cole. So our main provider for medically tailored meals is through Mom's Meals. And the biggest reason is scale and reach. We're not trying to say that, you know, you can't use anyone else, but just in our Eastern Kentucky, we don't have another medically tailored meal provider that is approved with American Diabetes, American Heart Association dietary guidelines. And that can also deliver meals to the home. So when we think about disabled, when we think about those who lack reliable transportation, and then preferences, people don't always want to cook. They don't want to prepare their own food. So that's where medically tailored meals plays a really strong role in that user preference. And then the second piece, so Cole mentioned step down care. We sometimes like to think of it as stepped up care, meaning, you know, you start with, here's nutrition education. Well, it's not working. Now what do we move you on to? Grocery. Oh, that didn't work. Now we move you on to medically tailored meals. So that's where we talk about those who have uncontrolled hypertension. We need to get them controlled. And typically a medically tailored meal can do that pretty fast relative to a grocery or a meal kit. Yeah. So that's our provider was Mom's Meals and still is for our work right now with the American Heart Association and our continued work. That is our provider. And they can come in different packages. So I'll let Cole chime in a little bit on just the different options that are offered.
Yeah, absolutely. Thanks for that. And yeah, to your point, right? They're fully like customizable. So, right, within our model, we know power of choice is so important to members to be able to kind of pick and choose the meals that they want to receive. And it's going to help just increase satisfaction, consumption, and just overall success of the program. There's a question about like culturally diverse options. Yes, right. At Mom's Meals, we provide meals across all 50 states. So we serve a very diverse population. So we need to make sure our meals are very diverse as well. So they can take a look at what options are available and kind of hand select the meals that are more appealing to them. We're continually building out that culturally diverse section right now. It's pretty broad as it is today, but always looking to expand at a deeper level. We also just recently added like halal and kosher to the offering. So yeah, it is kind of at the forefront of our mind, and our goal is to make sure that people of all ages, ethnicities, populations have meals that they can choose from and meals that they can enjoy.
I'm going to hopefully Cole can help me on this one. So this next one is, can you give a high level summary of the capitation rate, ALR and MLR? Also, was there any financial outcomes addressed? So I'm going to do that last one first. So our health economist right now is actually running that data on our return on investment and cost effectiveness. So I can't report on it yet, but that will be forthcoming. So the MLR in our state, I believe, I've gotten word that the value added benefit will be them. Now Cole's going to interrupt me and tell me if I'm right. Part of MLR or not part of MLR? There's something that I'm missing that I know our managed care plans are excited about, that they can count their value added benefit toward MLR. So help me out, Cole.
Yeah, I think it's kind of still being defined. Each state is so different. Typically, like what we've seen in other states is like that's why these pilots and VAB programs have been so critical to just kind of lay the groundwork and foundation to evolve these programs into larger funded resources, right? If we can show a VAB or pilot was successful to the state and bring them local outcomes, if we're able to offer this to a small group, why not expand that funding source to be able to offer to more populations for a longer duration of time and then make even a deeper impact, right? It depends like if states end up structuring this under an ILOS program or an 1115, right? Those are two completely different things. They're both being pulled from that medical spend. With ILOS, there are some limitations where you can't exceed 5% of that capitated rate. Anything over 1.5%, CMS is going to auto approve. If it goes beyond 5%, there is a cutoff. With 1115, there's no limit on that. 1115s are also approved for a 5-year period. So there's a little bit more sustainability, and there's a lot more that goes into the design of 1115. So we've seen states kind of attack this two different ways. So yeah, it really just depends on which model the state is pushing out. And if you have any, and I'm not sure like which state you're located in that asked the question, but happy to connect offline and share some more specifics as to like what is most relevant in that respected state.
And then what solution for engaging clients? So we text message, phone call. Those are our ways. Those are the two primary ways of text message and phone calls. So we and on our team have 2 referral coordinators that their whole job is to engage with patients. That's their whole job, all related to food. So again, we have that high touch patient engagement. And then how did we collect health metrics in a HIPAA compliant way? So we have HIPAA authorization. So I am housed at the University of Kentucky, and we have a healthcare partnership, meaning UK healthcare is actually part of University of Kentucky. And so that allows us to have HIPAA authorizations with UK healthcare, U of L, which is in Louisville, Health, Appalachian Regional Healthcare, which is ARH. And then now we just included Pikeville, and I'm missing a federally qualified health center in our eastern part of our state. So that again is a key part, and we're not trying to take away from, Mom's Meals or any of our food providers, but they don't have the capacity to have those HIPAA authorization agreements with those healthcare providers. It's just very cumbersome. And so we can fill that void, so that way we can track those patient health outcomes over time. Someone wants to circle back. I think we have about a couple more minutes. Yep. They have heard the opposite from CMS, that these Medicaid nutrition benefits could impact SNAP. So if you have anything written that it will not, I will share what our state has said. So we were in a meeting with our, Medicaid commissioner and our secretary. And so how it's structured right now, this year with value added benefits, and then the following year with in lieu of service, they did not foresee that would impact their SNAP eligibility. Now, maybe they'll get something back from CMS, but that is what our Secretary of Cabinet Health and Family Services and our Commissioner of Medicaid said on Friday, that it would not impact their SNAP benefits. And that's hence why we wanted a SNAP referral person housed. Now, we know, there's legally you can't have Medicaid enrolling into SNAP, but we are not Medicaid. So I think that's the difference there. But maybe if you know, Jordan, maybe you can also send me, and so then I can follow up. We can both help each other out.
I don't think there are any other questions. Not seeing any others that came through. Yeah.
Yeah. Well, I just want to thank everybody for your time and participation today. Hopefully this was somewhat meaningful of how to, build this out in your own state. I'm happy to answer questions. You can send me an email and I'm happy to help you out further.
Great. I think with that, again, I just want to thank everybody for joining today. It was so fun to be able to connect and share the great work being done. Eric, I don't know if you wanted me to hand it back off to you for a closing, but if not, I appreciate everybody's time today, and always appreciate MHPA for the partnership and giving us the platform to be able to speak to everyone today.
Yeah, no, I will just echo what everyone has said. This was an incredibly informative session. I appreciate you guys coming on, sharing the model, sharing how it works, sharing the partnerships. I think this is an amazing thing. I think everyone on this call is super excited to track to see how it goes forward, and are looking forward to more results. So like they said, with that, feel free to reach out. They have been very kind to leave their email addresses there. If you can also reach out to MHPA, we'd be happy to connect you as well. And as a reminder, this session was recorded, so you will be able to revisit it on MHPA's YouTube channel. With that, I will thank everybody again and tell you to have a great afternoon. Thanks, everybody.
Thank you, guys.